This means heart. It causes a diverse set of clinical manifestations ranging from TIA, strokes. Hello?
Yeah, Venkat?
Sir, audible now, sir?
Yeah, go ahead.
Aortic aneurysms is to lower extremity arterial occlusive disease. At molecular level, these hypercholesteremia and inflammatory cells play a key role in development of this atherosclerotic plaque. The major risk factors include hyperlipidemia, hypertension, cigarette smoking, positive family history, diabetes mellitus, obesity, lack of exercise, and poor dietary habits. A small gist on physiology and metabolism of lipids. Lipids are generally hydrophobic in nature and they are basically insoluble in blood. These forms a compound called lipoproteins together with phospholipids and a proteins known as apolipoproteins. We can see a picture there where a lipoprotein molecule is shown, which shows multiple lipid components together with phospholipids and apolipoproteins. This spherical particle is water soluble and can be carried in the blood for various to various cells for metabolism and storage. Coming to the lipoproteins classes and structures, we have basically 5 major lipoprotein components based on the composition and size and electrophoretic mobility. They are chylomicrons, VLDL, intermediate density lipoproteins, and LDL and HDL. You can see here from the diagram, these chylomicrons are 90% of triglycerides, amounting the high risk factor, and they have very less number of proteins. Whereas VLDL have 65% of triglycerides, IDL have 30%, and LDL have more number of cholesterol, amounting 50%. And our good cholesterol, HDL, have more number of proteins other than other cholesterol levels. And each lipoprotein is characterized by the specific apolipoproteins, which are marker for them helps in easy identification of the lipoproteins. Coming to the characteristics of their lipoproteins, we can see the chylomicron, though the density is less, the mean diameter of the chylomicrons is 500, and in electromobility, they remains at the origin. The basic source of chylomicrons are intestine, and the main function of chylomicrons are transport of exogenous triglycerides. VLDL, the source is liver, and they accumulate in the pre-beta origin of electrophoresis, and they helps in transport of endogenous triglyceride synthesis in liver. Ideal, they are broad beta level of electrophoresis, and they are due to catabolism of VLDL, and they are precursor of LDL. LDL, they helps in cholesterol transport, and HDL, they are the main sources liver, intestine, and catabolism of chylomicrons and VLDL, and their main principal function is reverse cholesterol transport, thereby reducing the blood and plasma cholesterol levels. So the term LDL and LDL, we call them bad and good cholesterol because this LDL transport and stores cholesterol within bloodstream, whereas the HDL, the good cholesterol, regulates LDL storage and promotes excretion, thereby reducing the accumulation of cholesterol in the bloodstream. Coming to pathogenesis. As we all know, the basic pathogenesis of injury hypothesis. Normally, our endothelium is coated with glycocalyx, which repels any accumulation of cells within the endothelium. But any injury to endothelium causes expression of adhesion molecules, namely ICAM and VCAM, which causes adhesion of monocytes and monocyte adhesion and migration of these monocytes into the intima level, where these turned into macrophages, and they eat up the cholesterol and forms the foam cells, which is the first microscopic depiction of the initial lesion of the atherosclerotic stages. You can see the first initial stage lesion is the isolated macrophage foam cells. Then these macrophage foam cells, they further accumulate and they stimulate the further reactions, causing smooth muscle migration and formation of atheromas and fibrofatty atheromas. So the stage of atherosclerosis includes 6 stages. First is initial lesion, typically a type 1 isolated macrophage foam lesions, which are basically microscopic. The first visible lesion is a fatty streak, mainly intracellular lipid accumulation, and followed by type 2 changes and small extracellular lipid pools. Type 4 is atheroma lesion, type 2 changes with extracellular lipid accumulation. Type 5 is fibroatheroma, and type 6 is complicated lesions, where the surface of fibroatheroma becomes defect, and it causes complications such as hematoma, hemorrhage, and thrombus formation. Regarding the clinical correlation, the first three stages are clinically silent, and whereas the type 4 and type 6, type 5 and type 6 may be clinical silent or overt. Now, the fate of atherosclerotic plaque. We can divide the fate of atherosclerotic plaque in two phases. One is the early atheroma either goes into stabilized plaque or into vulnerable plaque. We can see that in stabilized plaque, after you have taken adequate treatment or your lifestyle modification, the stabilized plaque is small lipid pool and thick fibrous cap, and lumen is preserved due to as the vessel undergoes complex. And if the treatment is not at a complete level, then it becomes a vulnerable block where it consists of a relatively large lipid ball with a thin fibrous. Thin fibrous cap measures about less than 100 micrometer. Complication of this vulnerable block is that it causes thrombosis of plaque, superficial endothelial erosion, intraplaque hemorrhage, and erosion. These manifest as MI, thrombosis of once these ruptured plaque heal, they forms a fibrous plaque with a very narrow tube. Coming to atherosclerotic target lesions in various risk factors, in age, as the age progresses, the most atherosclerotic includes the distal arteries. In male gender, both proximal distal arteries are high risk for atherosclerosis. In diabetes, as we know that distal pedal arteries are more prone for atherosclerosis. Hypertension, there is a uniform distribution of atherosclerosis risk. In hypercholesteremia and concurrent smoking, large arteries are more affected for rather than the distal arteries. Comes the diagnosis of these atherogenic lipids. First, screening. The adult treatment panel 3 of National Cholesterol Education Program recommends that all adults more than 28 should be screened for hyperlipidemia every 5 years. Initially, the test cholesterol, triglycerides, HDL, and LDL. If the total cholesterol is more than 200 and HDL is less than 40, it recommends fasting lipoprotein profile. Fasting lipoprotein. Then coming to fasting lipid profile, both LDL and HDL are equally more predictive in determining the atherosclerosis risk factors. Whereas the total cholesterol is not a good predictive risk factor, and elevated triglyceride is also not a good factor. It's not a good predictor of the disease progression. Whereas the elevated triglycerides in presence of type 2 diabetes mellitus and metabolic syndrome, it is an increased risk factor for cerebral and vascular disease. LDLP, which is measured using a NMR study, also reflects the truly reflects the profile of the patient. And measurement of apoprotein level also reflects the true risk level. Now there are certain biomarkers available which helps in atherosclerosis, identification of atherosclerosis and its progression. So we can see here in foam cells and fatty streak and intermediate lesions, there is normal CRP level with the normal LP-PLA activity and MPO activity. Whereas in case of atheroma and fibrous plaque, there is high CRP, HSCRP as we very specific, and lipoprotein PLA2 activity with normal MPO activity. At this stage, we can diagnose the risk factor of the patient. And once the complication occurs, there is high CRP level, lipoprotein PLA2 activity, and MPO activity. These are now what we see is the biochemical markers. Now comes the true identification of the vulnerable plaque. Yeah, we can quantify the plaque through imaging modalities to IVUS, our intravascular ultrasound, determines the true extent of the size of atherosclerotic plaque. It also determines to which artery has been remodeled in response to a plaque. So in IVUS, the heavily calcified plaque is seen as highly echogenic with posterior shadowing, whereas a fibropathic plaque is seen as less bright and lack post shadowing, and soft plaques are echolucent and darker. You can see in the picture, I have marked the calcified plaque with a posterior shadowing. And a modification of IVUS is the Bristol histology IVUS, where the dark green indicates a fibrous and yellow green is fibrofatty, white on the calcified, and red is necrotic. They have a study is made on in characteristics. The capital study. It concludes that it's more sensitive in detecting the fibroacidosis than other, and there's better prediction of plaque behavior in response to treatment also. So the IVUS characterizes a vulnerable plaque, where is a positive remodeling with thin cap and lipid pool with a high eccentricity. The IVUS characterizes vulnerable. Can use to detect the MRI with gadolinium loaded missiles coupled with antibodies to scavenger receptor. CT used with the novel iodinated nanoparticle contrast agents to detect the inflammation in the atherosclerotic plaque, and contrast enhanced ultrasound by attaching the VCAM1 to the microbubules and identifying the areas of active adhesion molecule expression. Others are IVUS modified, such as integrated IVUS and OCT system, multi-frequency IVUS imaging, IVUS with NIRS, and IVUS with photoacoustic imaging. These imaging modalities give high resolution of thin fibrous cap and better assessing the lipid composition of plaque with infrared. Now comes the goal of the treatment. Goal of treatment includes normally we categorize the patients based on the risk factors into 0 to 1 risk factor, 2 plus risk factor, and patients with coronary heart disease and coronary heart risk factor equivalent based on the Framingham's criteria. So the goal should be LDL cholesterol should be less than 100 for coronary heart patients and coronary risk equivalent. With multiple risk factors, it should be less than 130, and 0 to 1 risk factor should be less than 160. And non-HDL cholesterol level should be 130, less than 160, and less than 190. So it's a goal of treatment. If this, if you are above this levels, then you have to go for either in a coronary heart disease patient, we should initiate a therapeutic lifestyle. We should initiate both therapeutic lifestyle and moderate above 30. If the lower is above 190 only, we should consider therapy. Above 190, we should consider therapeutic lifestyle. Then what is this therapy? The pharmacology therapy is based on the plant-based diet, which any animal source of food is ideal for lowering the saturated fat should be less than 7% of total calories, and dietary cholesterol should be less than 200 milligram of that. Should include more vegetables, greens as a part of low fat diet. And coming to the physical activity, minimum of 30 to 60 minutes moderate physical activity 5 to 7 days per week, in addition to increased activity in daily lifestyle activity recommended by the ACC and AH. So, saturated fat found in animals and trans fatty acid found in these fast foods, they tend to remain solid at room temperature. They raise cholesterol, increase heart disease, keep the intake low. Whereas the plant-based and polyunsaturated found in fish and certain vegetables, they tend to remain liquid at room temperature. They lower total cholesterol, may reduce the risk of heart disease and moderate intake. Another slide depicting the value of unsaturated fatty acid. Saturated fatty acid keeps your cell unhealthy, whereas the trans fatty acid makes your cell dysfunction and raising the LDL levels. Pharmacological therapy. Pharmacological therapy, lowering cholesterol, LDL cholesterol, increasing HDL, and decreasing triglycerides, the prime goal of all pharmacological drugs available. The most commonly used is HMG-CoA reductor lovastatin, simvastatin, atorvastatin, rosuvastatin. They act by decreasing the cholesterol synthesis by inhibition of HMG-CoA reductase. The adverse effects of these includes a slight rise in serum transaminase level, but they become normal once we reduce the dose, and muscle tenderness and myopia are very rare. Bile acid sequence, cholestyramine, cholestyramine, they decrease bile acid absorption, increase HDL receptors and hepatocytes. Most common is flatulence. Fibric acid derivatives, gemfibrozil, benafibrate, fenofibrate, they increase lipoprotein lipase activity, decrease release of fatty acid from adipose tissue. The most common adverse drug reaction include skin rash, eosinophilia, and impotency. And nicotinic acid, they decrease production of VLDL. Common adverse reactions include flushing, heat, and itching. The main effect of these is they decrease LDL and increase HDL levels. Many newer cholesterol lowering agents have been introduced. One is omega-3 fatty acid found in fish and other marine animals, soybeans, and other vegetables. They mainly include EPA and DHA at a dose of 1 gram daily, reduce the risk of sudden death. Hypotriglycemia effect without significant adverse effect even at higher doses they have. Another novel drugs were toracetrapib and anacetrapib. These are cholesterol esterase transport protein inhibitors. They inhibit the proteins that transport the HDL into the cells, thereby increasing the HDL level and making good cholesterol more. And there are two types. One is homotypic and heterotypic, inhibiting both homotypic and heterotypic transfer. And one dalcetrapib inhibits only heterotypic transfers. Another novel agents are PCSK9 inhibitors. Proprotein convertase subtly kicks in type 9, increases LDL by interfering with hepatic LDL receptor cycling. These includes alirocumab, evolocumab, and bocizumab. These have been effective in reducing the LDL level by 60% in patients. Novel agents include the inclisiran, interfering RNA targeting the PCSK9 messenger RNA, inhibition of PCSK9 synthesis. Bempedoic acid inhibitors, which inhibits the ATP citrate lyase, which upregulates the LDL receptor. And AKCA-E ApoA LRX is an antisense oligonucleotide targeting lipoprotein A. It can lead to significant reduction in lipoprotein up to 90%. A short list on familial hypercholesteremia. Familial hypercholesteremia is nothing but an autosomal dominant disease caused by mutation of genes encoding either a LDL receptor or ApoB protein or PCSK9 gene or adapter protein, which precedes the clearance of circulating LDL. Mutations in these genes result in loss of this function of this molecule and contribute to elevated level of LDL. They are heterozygous and homozygous. Heterozygous, where only one abnormal copy of gene may have, these patients may have premature CAD at the age of 30 to 40. Whereas homozygous very catastrophic, where the child has CAD, where the patient has CAD at even the childhood. And based on the mutation of LDR gene, the 5-6 classes of LDR mutation classification system has been introduced. So what's the difference between the homozygous and heterozygous familial disease? There is one gene influence heterozygous and two genes influence homozygous. The LDL level cholesterol is more than 190, whereas in homozygous more than 400. Onset of CAD is between 30 to 60 years, whereas in childhood in homozygous. They respond very well to drug therapy, very poor response to drug therapy in homozygous. Most common is heterozygous familial hypercholesteremia and rare is homozygous. The diagnostic criteria for familial hypercholesteremia include Premature family history, clinical history with premature CAD, the physical signs that should raise the suspicion of familial hypercholesterolemia is tendon xanthoma, highly specific xanthelasema, and arcus senilius, coronal arcus, highly specific less than 45 years of age. And laboratory examination includes high LDL levels greater than 250, and physical genetic test are available for identification of gene mutation in LDR, ApoB, and PCSK. And there should be no secondary cause of hyperlipidemia. Diagnosis, as I said already, this is my gene receptor analysis of PCR, next generation sequencing, RNA sequencing, and cell cultures are available. Fibro cell cultures are available today to detect the LDR defects. Treatment includes a fat modified heart healthy diet, plus in case of heterozygous we start with statins, and we have PCSK. If not, we go for lipoprotein apheresis. Whereas in case of homozygous, we start with the statins and we go either go for with our lipoprotein apheresis also. It's indicated in initially itself is indicated a first line of drug, first line of treatment in homozygous. The novel treatment also has been introduced in the familial hypercholesterolemia, where the gene therapy, gene editing using CRISPR Cas9 a system to edit the mutated gene copy. Thank you. Hello, sir.